Today we're going to be talking about antimicrobial chemotherapy. That's a fancy way to say we're trying to understand how chemicals could be used to specifically target microorganisms in order to treat a disease. So we want to look at the cellular structures that a particular microorganism has, and then based upon the way in which an antimicrobial kills an organism or inhibits its growth, we want to be able to predict whether one antibiotic, for example, will be effective against a particular type of microorganism. That's really important because we want to make sure that if we are in the business of prescribing treatment for a disease, that we're prescribing antibiotics that are actually going to be effective against the bacteria that are causing the infection. We need to begin off with a little bit of terminology because we have a really broad umbrella term. Chemotherapeutic agent means any chemical that's used to treat a disease. Now, some chemicals are used to treat diseases caused by microorganisms. These are called antimicrobial drugs, and every antimicrobial drug is a chemotherapeutic agent. However, not all chemotherapeutic agents are antimicrobial drugs. We know, for example, that chemotherapy is used to treat cancer, and at least that particular disease is not directly caused by a microorganism. So there are other chemotherapeutic agents, not just those that are used to target a microbial infection. Now, we can get even more specific. Antibiotics are a type of antimicrobial drug. Classically, antibiotics have been defined as a substance produced by one microorganism to kill or inhibit another microorganism. Now, some of you have actually asked me about this, thinking about how certain kinds of fungus might release something that will kill off bacteria. It's about competition in that particular case. Microorganisms are getting more of the plenty if they can kill off their competitors. It's not always about competition, however. We also know that sometimes antibiotics are used by microorganisms in order to communicate. Now, this is the natural world where we're seeing how antibiotics are produced naturally, but we saw nature's good idea and we began extracting antibiotics, things like penicillin, from things like Penicillium chrysogenum, which is a mold. However, once we saw nature's good idea, we thought, hey, nature, good job, but we can do even more. And so mad organic chemists now synthesize antibiotics on the benchtop. So these fall outside of that original definition because these antibiotics are synthetic antibiotics or partially synthetic antibiotics. Things like broad spectrum penicillins, ampicillin, amoxicillin that have become very famous are partially synthetic. We need to think anytime we're treating with an antibiotic about its therapeutic index. That is, we need to understand how toxic the particular antibiotic is to us versus how toxic it is to the bacterium or other microorganism that's causing the infection. Now, in order to sort of understand this toxicity, I want to look at a cartoon. This is a cartoon that appeared a while ago in the local school newspaper, but I thought it was so great I tried to remake it. I wasn't very good at it, but I hope that it drives home this point. If you were to overdose on M&Ms, it would literally take a mountain of M&Ms. You would have to eat a lot of M&Ms before it would kill you. So the toxic dose of M&Ms is much higher than the toxic dose of cyanide. It doesn't take very much cyanide to permanently harm you. So with that being said, we understand that a substance that takes a greater toxic dose, that is a higher value in the numerator, will be more selectively toxic. So the larger this number, the greater the therapeutic index. Said another way, it takes a really lot to kill or inhibit us, but it takes very little to kill or inhibit the microorganism. So the therapeutic dose, if that's low, and the toxic dose is high, then we know that the selective toxicity is going to be really awesome. It takes a lot to kill or inhibit us, but it doesn't take very much to kill or inhibit the pathogen that's causing the disease. Interestingly, while therapeutic dose or therapeutic index is the most valuable way to think about the antibiotics that we work with, a lot of times we see something called the minimum lethal concentration and the minimum inhibitory concentration, or the MLC and the MIC. The minimum inhibitory concentration is determined by serially diluting the antibiotic and then visibly noting the lowest concentration of antibiotic that inhibits the growth. The minimal lethal concentration, by contrast, means that you then have to subculture out of that antimicrobial containing well and find out whether or not the microorganism comes back into being viable once you put it into media that doesn't contain the antibiotic. Then we know that it's actually permanently dead. But what you'll notice about MLC and MIC, so commonly reported, is that they tell us absolutely nothing about toxic dose. They only tell us about therapeutic dose, the amount that it takes to impact the microorganism. It doesn't tell us about how it hurts or doesn't hurt us as the hosts. So let's talk a little bit about the particular sites on a microorganism that tend to give us the greatest selective toxicity. So recall that if therapeutic index is high, then we know that the selective toxicity is really quite good. We tend to try to work with antibiotics that target sites on a microorganism that we don't have so that we can maximize selective toxicity. And I know that many of you right now are simply yelling at the screen and you're saying, Rachel, peptidoglycan, target peptidoglycan, because we don't have it. Microorganisms, bacteria, only bacteria, in fact, have it. So if we look at the reminder of the gram-positive cell wall structure, we can zoom right in and tell ourselves again that the outer layer of a gram-positive bacterium is a thick layer of peptidoglycan. So if an antibiotic targets peptidoglycan, then it'll be particularly effective in treating a gram-positive cell wall. Whereas we know with a gram-negative, the outer membrane precludes many antimicrobials from getting in and even getting to the peptidoglycan. So inherently, a gram-positive is going to be more affected by an antimicrobial that targets the peptidoglycan than is a gram-negative. Now, depending upon the antimicrobial, there may be absolutely no impact on a gram-negative. That is, if it's a very large antibiotic, it won't even be able to get in to the outer membrane of a gram-negative cell. A good example of that is vancomycin. Let's take a minute to look at the most common group of antibiotics that target peptidoglycan and think a little bit about how they work and therefore what kinds of organisms they target. The beta-lactam antibiotics include the penicillins and the cephalosporins. Now, the original penicillins are natural. They're isolated from the Penicillium mold. And the original penicillins, were only effective against gram-positives because of their ability to target that outer layer and some very unusual gram-negatives. However, later generations of penicillins have been synthetically produced in which this R group is different. For example, in amoxicillin and ampicillin, this has been modified so that we've gained a broader or extended spectrum. And now some of those later derivatives of the original penicillins can target gram-negatives. Amoxicillin and ampicillin can. Now, the cephalosporins are similar in nature. They were also originally isolated from a mold and originally were effective mainly on gram-positives. But now we have many generations of cephalosporins, and in fact some of the very most recent generations of cephalosporins have been modified in their R group to become very, very impactful against certain gram-negative pathogens. In fact, some are particularly derived just to be effective on gram-negative pathogens of the cerebral spinal kind of neural tissues, so they become very specialized. What I want to draw your attention to is that in all penicillins and cephalosporins, or beta-lactam antibiotics as a whole, they have this beta-lactam ring, right? That makes sense. They have a ring called the beta-lactam ring. It's a 4-membered ring, and it's absolutely essential to the activity of a beta-lactam antibiotic. That is to say that if an antibiotic loses that 4-membered ring, it is no longer going to work. Now, many bacteria take advantage of that, and in fact, gram-negatives, even more so than gram-positives, are likely to produce this group of enzymes called the beta-lactamases. So in a gram-negative, not only in a gram-negative do we see the peptidoglycan being protected by the outer membrane, but also we see a lot of gram-negatives secreting these enzymes. And bear in mind, I'm just doing this cartoon style, that act like scissors that cleave the beta-lactam ring. We know that, in fact, there's a lot of chemistry involved in that. So the beta-lactamases or the penicillinases cleave this 4-membered ring. That is one form of resistance. So many antibiotic-resistant organisms create beta-lactamases. Let's get a little bit deeper into this whole notion of antibiotic resistance and how it is enacted, but also how we sometimes try to get around it. So if we think about this gram-negative bacillus over on the right as potentially being a bacillus that secretes out a beta-lactamase, so we're just going to show this kind of cheesily that this is secreting an enzyme, and that this enzyme is kind of a Pac-Man enzyme that can chew up the 4-membered ring that we see in beta-lactam antibiotics, right? It can cleave that ring. Now, what we recognize then is that if we prescribed something like amoxicillin to treat this gram-negative bacillus, it would be ineffective because it would just rapidly chew up the amoxicillin. So what we've done is we've actually found drugs that are not just the amoxicillin, but we might prescribe something that is amoxicillin plus the addition of a beta-lactamase inhibitor. Clavulinate is one of those. So I'm just going to show with a different color here that we have an inhibitor of this enzyme. So this is amoxicillin plus the inhibitor. And then therefore the amoxicillin can go to work on the peptidoglycan of this gram-negative because the clavulinate is going to work on the enzymes that would inactivate the amoxicillin. Now, let's think just a little deeper about how this amoxicillin works. The amoxicillin actually works by inhibiting the enzyme that builds the tetrapeptide chain. So if we picture that when we zoom in on the peptidoglycan, what we would be looking to inhibit is literally the enzyme building the bonds within the tetrapeptide chain. Interestingly enough, that enzyme is named penicillin binding protein because we realized that it was inhibited by antibiotics like the penicillins before we realized that it was building the tetrapeptide chain of peptidoglycan. So it's actually stopping the enzyme that makes this tetrapeptide chain. So we say broadly it's inhibiting the cross-linking of peptidoglycan. So that is the way in which the combination therapy would work if we knew we had a gram-negative bacillus that was secreting enzymes that could inactivate the more expansively effective penicillin, amoxicillin. Now, let's look at a scenario in gram-positives. We could talk about methicillin-resistant Staphylococcus aureus. Now, methicillin-resistant Staphylococcus aureus is also penicillin resistant. So if you tried to prescribe penicillin, right, we know that penicillin would inhibit the enzyme that targets or that builds the tetrapeptide chain, But in MRSA, it's secreting enzymes to inactivate the antibiotics to cleave that four-membered ring to stop it from being able to inhibit the cross-linking of the peptidoglycan. The next layer of treatment is methicillin, but now the gram-positive cocci that are MRSA are resistant to methicillin as well. So sometimes then what we do in order to try to treat these already resistant gram-positives is we then try to use something called vancomycin. Vancomycin is another antibiotic that also targets the peptidoglycan. Now what it does is it actually binds to a tetrapeptide chain while it is building. So let me see if I can give you a kind of visual look at that. Vancomycin comes in, and instead of the next amino acids in the chain binding, vancomycin binds, and it's this huge molecule, and it binds there, and then therefore the rest of the tetrapeptide chain can't get built. However, as I just mentioned, vancomycin is huge, so vancomycin cannot get in to the outer membrane. It's like, no go, you're not getting in here. So vancomycin is absolutely inappropriate as an antibiotic to prescribe against gram-negatives at all. Now, some of you have known someone, you've had a friend who's had MRSA, and you know that they then had to maybe in some cases be treated with vancomycin. You also recognize that they had to go to the hospital for this treatment because vancomycin is only utilized parenterally. Parenterally is a fancy term for non-orally. You can't just, take a couple pills of vancomycin. You have to get it intravenously. So this is a much more difficult route of administration. Thus, vancomycin we recognize as another antibiotic that targets peptidoglycan, but it's not a beta-lactam antibiotic. We might just jot a couple notes about vancomycin so we remember that it is large and cannot cross the outer membrane of a gram-negative. We also recall that it inhibits peptidoglycan cross-linking by binding to amino acids of an elongating tetrapeptide chain, therefore gets in the way of making that tetrapeptide chain. We also recognize that it is administered parenterally, intravenously, non-orally. So that makes it a last-ditch effort kind of treatment. Now is the time when I get to tell you that we are also seeing many cases of VRSA, or vancomycin-resistant Staphylococcus aureus. I'll end our coverage of those antibiotics that target peptidoglycan by looking briefly at bacitracin. Bacitracin actually inhibits the movement. Peptidoglycan precursors cross the cell wall. And this is effective in obviously inhibiting peptidoglycan synthesis, but it's also very effective in inhibiting transport in eukaryotic cells. So the selective toxicity is not good. Now, I'm going to leave that to you to tell me whether that means it has a very high or very low therapeutic index. Selective toxicity, not so good. Therefore, the only place we see this is in our over-the-counter triple antibiotic ointment that we put on our skin. And of course, our skin cells are already dead, so we don't need to worry about killing them. So we see this only used topically. Let's turn our attention to those antibiotics that target the 70S ribosome. Remember that bacteria have 70S ribosomes. We have 80S ribosomes. So targeting the 70S ribosome is a pretty attractive selective mechanism of inhibiting the growth of just bacteria and not too much harming the host. Let's begin by looking at the aminoglycosides. The aminoglycosides target the 30S ribosomal subunit, and they actually cause mistranslation. So by binding at the small ribosomal subunit, they tend to cause a problem with the tRNA and its accurate binding with the codon, and therefore this leads to mistranslation. Antibiotics that are aminoglycosides are often used to treat gram-negative bacteria that respire. So if you're thinking about some of the gram-negative bacteria like E. coli, that is a respiring bacteria. But then also, if we think about things like Yersinia pestis, the one that causes bubonic plague, the aminoglycosides like streptomycin, gentamicin, these are drugs, well, streptomycin, gentamicin has pretty poor selective toxicity. And then when we get to neomycin, neomycin has extremely poor selective toxicity. Again, please tell me what that means about its therapeutic index. Neomycin is the second ingredient in your Neosporin, so it's the next one that's only ever used topically. The tetracyclines also target the 30S ribosomal subunit and lead to the inhibition of protein synthesis. And then finally, the macrolides, and we'll use a different color to indicate the macrolides, they target the 50S ribosomal subunit. So they're targeting the large ribosomal subunit. So they too are inhibiting protein synthesis. So the tetracyclines include, well, of course, tetracycline, but they also include doxycycline. And doxycycline is commonly prescribed to treat particular pathogens that are often arthropod-borne. So for example, Rickettsia rickettsii, which causes Rocky Mountain spotted fever, and Lyme disease that's caused by Borrelia burgdorferi. I once went kayaking in Quebec in the Saguenay Fjord and came home with swollen lymph nodes, and my doctor said, I'm giving you doxycycline because if you have Lyme disease, we need to make certain that we treat it right now because there are later consequences of not treating it. The macrolides include erythromycin, but also the epically popular, at least right now, azithromycin or Z-Pak. Who's not gone to the doctor and gotten prescribed a Z-Pak? The appeal of Z-Pak is that typically you take like 500 milligrams on the first day, and then for like 2 to 5 days after that, you take 250 milligrams a day, but it only lasts for a very, very short period of time. And so people tend to complete the prescription before they feel better, which tends to encourage them to complete the prescription, which is one of the reasons that the Z-Pak is very, very popular. However, there are a lot of antimicrobial resistant strains that are not impacted by Zithromax, so that's important that physicians do a Kirby Bauer before they try to treat an organism with this, and that rarely happens. So let's talk a little bit finally about 2 additional antibiotic classes, those that target the DNA topoisomerases. So remember that the topoisomerases are involved with maintaining the supercoiling of DNA. So I've just drawn in a cheesy nucleoid on this gram-positive coccus to remind us that both the gram-negative bacilli and gram-positive cocci and all bacteria of all types have a nucleoid with a circular chromosome that has to be supercoiled, and that maintenance has to take place during replication. There have to be enzymes to relieve that supercoiling and allow that supercoiling. So inhibiting the DNA topoisomerases is a very very broad spectrum means of targeting bacteria, because you're not just hitting gram-positive cocci, you're not just hitting gram-negative bacilli. All bacteria have to, in fact, package their DNA. So one famous member of the antibiotics that target DNA topoisomerases is Cipro, or ciprofloxacin is the full name. Any of you who have traveled abroad for a very extended period of time, you've been prescribed Cipro in case you contracted any number of types of infection, ranging from a gastrointestinal pathogen to a lung pathogen to an STD. The Cipro can target varying genera of bacteria and therefore can be effective against a number of different types of bacterial caused disease. Of course, it's not going to do anything on a viral infection. There's one last group of antibiotics that I want to talk about, and those are the antibiotics that target cytoplasmic membranes. So destroying a cytoplasmic membrane and leading to diffusion of, essential ions and molecules out of the cell includes antibiotics like polymyxin. Now, polymyxin is obviously going to be pretty dang effective on a gram-negative bacterial cell with its two membranes. But when you think about it, the therapeutic index of this particular antibiotic is going to be extremely low, because polymyxin is also going to inhibit or kill our cells by diffusing gradients across membranes of eukaryotic cells as well. So we have just met the third and final ingredient in Neosporin. So Neosporin has the antibiotic that targets cell wall synthesis, bacitracin, the antibiotic that targets ribosomes, 70S ribosomes, neomycin, and the antibiotic that targets cytoplasmic membranes, polymyxin. So now you know a little bit more about your Neosporin, or your triple antibiotic ointment that you have at home to put on cuts on only on topical surfaces. Today in class, our exercise will center around applying these concepts and utilizing tables that give more details about each of the antibiotics we have just met. So we're going to think through some case studies and some deep thought critical questions. So looking forward to it.